And in terms of the agenda, we'll start off with a short presentation by Shola summarizing SmartHIV Solution. So that will be the first 20 or 25 minutes. We'll then have almost an hour demonstrating SmartHIV Solution, but in between you'll have plenty of opportunity to ask questions. And also the last 35 minutes is dedicated for some of our panelists. And again, an opportunity for you to ask questions. I suppose we can, depending on the size, you can unmute yourself as well if you wanted to ask a question at the end. So I'm going to leave the floor for Shola to do a quick demonstration, a presentation, of SmartHIV Solution. Shola, do you want to start sharing your screen? Yep.
Yeah, thank you, everyone. This is just a brief summary of the technology that we're talking about, which Ellen will be demonstrating later. And we want to seize this opportunity to thank the African CDC for giving us this platform to be able to showcase this solution. We have introduced ourselves. We are the co-founders of Bohemian Smartlytics. However, we've got a team of different experts working with us. And we also have a scientific advisory group, which is advising us on technical and scientific related issues. Just to say that this event has been put together by Bohemian Smartlytics, and that the panelists have no financial interest or relationship with the company. The company has received no financial support from anybody. The development and putting together this webinar is solely the responsibility of the co-founders. Just to set the ball rolling as an introduction, we all know this data by heart. We know that we are now stuck with 38 million people living with HIV globally. We can also see that the number has stabilized over the past 3 to 5 years, which means maybe we've done a lot of work and seen great results from preventing new infections, and also that the ARVs are working really well and people are living longer now. But one thing we can agree to is the fact that even if there's a vaccine today, we're stuck with these 38 million people that we need to take care of. And as they grow older, it offers a different kind of challenges in terms of managing this patient population. We were thinking, how come that digital innovation has not found its way into HIV? And we thought maybe there's no need for it. We end up having to run a study to assess if there's any need or any gap within the HIV disease or any opportunity to leverage digital innovation. And it's very striking that everybody we surveyed actually needs one kind of support or the other. So of course, the needs are different depending on the people surveyed. So patient needs daily support, clinician needs clinical decision-making tools, service managers need planning and budgeting tools, which are easy to use. And then, despite the fact that this solution was just a concept, 86% of people that we surveyed actually believe in the solution, and 93% says they will use it if it were to be available. And a bit over 3/4 actually says they are positive about it and that they will recommend it for use. So this gave us the kind of motivation we needed to actually start the development of the solution. And what is this solution about? Based on the survey, we identified key stakeholders. Of course, the focus is on the patient. It's a very important stakeholder. Also, are the administrators, the service managers, and policymakers. We also have the healthcare professionals, especially the clinicians, nurses, and also support workers. They're also the clinical researchers and trialists who wants to test new innovative therapy. So we came up with a solution for each of these stakeholders with the focus on the patient. We know that the reason why all these stakeholders exist is because the patient will have a disease and this virus lives in patients. So we decided to create a solution that solves every need of every stakeholder. So we've got a SmartHIV clinician which supports clinicians to provide the best possible treatment for patients. We know that, as I mentioned earlier, patients are growing older, they have other comorbidities, and then it comes with challenges on what is the best and optimal therapy for the patient, given all the patient attributes. And mind you, this solution is different from other solutions because we are not using any models here. We're just collecting all available evidence and presenting it in an easy to use dashboard for patients and for the benefit of the patient, for clinicians and for the benefit of the patient. And we have the SmartHIV app, which is a mobile app that helps patients to manage their disease on a daily basis. And it also gives them some kind of empowerment to take certain decisions, as well as engage healthcare professionals and be involved in their daily management of the disease. We have the SmartHIV Manager, which is a planning and budgeting tool, which helps to identify the needs of a service, either at local level, at regional level, at global level, and tends to also present what are the budgets that will be needed, the required budget with different scenarios. HIV trialists support HIV clinical researchers to be able to target patients for recruitment, especially because within the app, we ask patients if they are willing to participate in the clinical trial, such that they can be connected with the right clinical trial when those clinical trials are live. One other thing that we derive from this is the fact that in certain countries, they have a handful of choice in terms of ARTs. However, by enrolling patients in clinical trials, patients will have access to innovative medicine. On top of this, we build an advanced analytics platform, not only among all the suite of SmartHIV solutions, but also being able to integrate existing systems, EMRs or EHR, whatever system that people currently use. We can integrate this with the solution because we know that it's difficult for people to get rid of the current system, but this portrays an opportunity, offers an opportunity to be able to integrate any existing system within the SmartHIV solution. Maybe I should pause a bit if there are any immediate questions that are coming up.
I mean, if you have any questions, you could go ahead and type it in, okay, into chat. You don't have to wait until the end. You can type. We should be able to even answer the questions straight after the presentation.
Okay, I can continue. So the next few slides is just trying to position our SmartHIV solution within stakeholders' ecosystems. And I think this is very important so that people try to associate each of these stakeholders and how our solution can address some of the challenges. So within the digital ecosystem, these are some of the stakeholders, and we can see that the center of this ecosystem is the citizen and the patient. Actually, there's really a thin line between citizen and patient, and this is where the app fits perfectly. And within the app, we have 3 profiles for patients, for clinicians, and for a body. So, which means at the citizen and patient level, we also carry along the community level via the body, because a body can be a friend, can be a family member, can be a support worker or a community worker supporting the patient within the community. And within the other surrounding stakeholders, the policymakers, providers, administrators, either the SmartHIV manager, the SmartHIV clinician for healthcare professionals, the trialists for private entities and healthcare companies. This fits perfectly well within the digital ecosystem. And one of the buzzwords also in implementation is the socio-ecological framework, especially for people living with HIV, in terms of how the acceptability interact with access, and what are the factors that influence access and acceptability. And some of these are as a result of policy, healthcare financing, and guidelines. Within the healthcare-based factor is interaction with providers, amenities of care, quality of care, and so on. And in the community, you have care and support, stigma and discrimination, and also traditional healing. In the client base is part of awareness. Part of this is awareness, experiences, expectations, and income. And if we look at this and we put it in perspective of SmartHIV Solution, SmartHIV Solution actually fits into this, into this paradigm, and supports, at different levels, either at client-based level or policy level, healthcare-based level, or even community level. And this is going to be very apparent when we start to do the demonstration. Another thing is the socio-ecological models around stakeholders' perception, or even client barriers and facilitators to retaining and re-engaging HIV clients in care. It doesn't matter how you look at it. This is either at the individual level, at the family or interpersonal level, at the community level, or at the institutional or structural level. And all this is taken into consideration and in the development of our SmartHIV solution. So our solution is right at the center of all these models. So it offers the opportunity to leverage this digital innovation in the holistic management of HIV, not only within the individual level, but also at the institutional level. And this is just, this is my final, the final slide, which just looks at the HIV pathways, the disease pathways, and how the app fits directly into taking into consideration from diagnosis up until, outpatient management in terms of comorbidity management, information needs, status disclosure, connecting with healthcare professionals, and also we have the quality improvement, strategy for stigma and discrimination built into it. And also we then have all the other supporting components of our solution, providing necessary support, either from the clinician perspective, from the trialist perspective, from the service manager's perspective, and then from audit, because we can also see how things are doing at the patient level in a platform that we call Auditlytics. So with this, we can measure and see the impact of policy decisions on patients. And the app is currently in the stores and ready for download. We've got absolutely amazing feedback. We had 3 focal groups, 2 in 2 centers in Nigeria, 1 in a center in Kenya, and the result has been very amazing. And the impact, we're continuously monitoring the impact, but we can already share some really good news about the impact this is having on patients. Thank you very much. That's my last slide.
Thank you for that, Shola. Thank you. Before we get started with the demonstration, I'm happy to take some questions. Really, there is no such thing as a stupid question. Please do not shy away. Fire as many questions as you can. Okay, you can always type your questions in while we're demonstrating, but please do not shy away. Ask as many questions as you can. I'm going to quickly start. The demonstration is in two stages, so there is a lot to cover and a lot to take in. Okay, that's a confession before we start. So what we'll do is we'll start with BSmartChart app, so the demonstrating the app, and then we'll move on to our web-based platform, which is demonstrating the other components of SmartHIV Solution, the manager, the clinician, and so on and so forth. That's where we kind of start to bring in all the needs of stakeholders, as Shola just mentioned in his previous slide. So the SmartHIV Solution is here to cater the needs of all stakeholders, but with a focus on patients, because clearly the evidence suggests that such digital solutions, especially like BSmartChart app that we're going to be demonstrating as an intervention, has a significant impact or the potential to support patients. This could be self-management, treatment adherence, reduction in stigma and discrimination. We'll see how that could that works. We're using the app, improve patient outcomes, and as I said, above all, empowering people living with HIV to take control of their disease. So what I'm going to do is hopefully the technology doesn't muck up. So can you see my screen, my mobile screen?
Yeah.
Okay, here we are. So again, let's get started with this. So the app, as Shola just mentioned, is on Play Store and App Store. You can download and install at your own time. Okay, so what we have is we've got 3 profiles. So we've got a profile for a patient, a profile for a healthcare professional. This could be a community health worker. This could be a clinician, and also I'm a buddy. So the buddy in this case would provide the psychosocial support or the mental health support for patients, where they can have honest discussions, and the buddy could help in terms of monitoring and supporting the patient throughout their journey within the HIV care process. So what we have is we've got a patient. Let's start with the patient profile. We'll go through how the interaction between clinician, buddy, and the patient works. Okay, you just need to bear with me. As I said, there's a lot to take in. Please ask questions wherever you need. So you could log in by creating an account using your mobile phone number or email. Assuming you've created your account, let's just log in as a patient. And here's an account. Just put in my credentials. Okay, here I've logged in to my patient account. So this is where you could also go to profile and settings and set yourself a PIN just to make sure that nobody has access to your app. Now, everything starts here with my survey. So there's about 15 categories of questions here: demographics, patient adherence, viral load, and CD4 CAD, and so on. And it's compulsory for all the questions to be answered. Now, where a patient has difficulty answering some of the questions, things like cardiovascular related questions, metabolic syndrome, these would require maybe the support of the healthcare professional, to help answer some of these questions, but they can always go back. Now, the survey is designed in such a way that users should be able to complete the survey periodically. So this could be weekly, monthly, quarterly, depending on their needs, or this could be, decided with their healthcare professional. And it kind of gives you the option. So it's, in subsequent My Survey completions, your demographics information may not change, your vaccination information may not change, or sexual health. So what would happen is these categories are removed so that you don't have to answer the same questions again. Okay, so it all starts with My Survey. Once you've completed My Survey, the questions, a lot of the data is used to populate some of the outputs. So let's start with medication, where you can set up your medication reminders. That's nothing got to do with My Survey, by the way, but this is a feature where users could set their medication, this could be HIV or non-HIV medication, so that they receive a notification 10, 15 minutes before they take the medication. And what we have is, if you tap onto it, once you've set your medication, obviously it gives you things like how many pills you've got left. It should give you some sort of a reminder when you have, say, 15 pills left, just to make sure you top up your medication. So there's that reminder. There's also the drug-drug interaction that we provide. So on this occasion, this particular patient is on HIV medication known as Stigma, and we're looking at some of the drug-drug interactions. So the patient is on some illicit drugs here, so cannabis. The likelihood of interacting with this particular HIV medication is highly likely. So that's information provided. Garlic, it's a grocery item that we consume on a daily basis, but it's, again, interacting. Now, this particular patient has a type 2 diabetes using metformin. The interaction is none. So there is this additional information provided. And we had from one of the users, this was a couple of weeks ago, where he said that he went to a hospital for a non-HIV condition. And the hospital where he had received treatment for his non-HIV condition was different to the hospital where he's treated for his HIV, because between the providers, there's no information shared, no data shared. And on this occasion, obviously, the clinician treating non-HIV condition had no idea of his HIV status, and the patient couldn't disclose his status either, HIV status. So due to stigma and discrimination, or the potential for a discrimination, he said he used the app instead to help him to find out whether if his HIV medication interacted with the non-HIV medication. So there's quite a lot of these kind of examples we're hearing from users in terms of this feature here. So that's the drug-drug interaction element within the medication section of the app. Now, there's the adherence here. This is based on self-reported adherence. So for this particular user, based on the survey, it's 52 out of 120. So we've calculated it as 43%. That's categorized as good adherence. But there's more information needed here, because we need to find out what are the causes of not adhering to their medication, and that's all in the reports section. So we're going to have a look at these causes in a bit more detail, and when we get to the reports. There's also suppression side. For the medication that the patient is on, the expected overall suppression is around 79%. And in order to hit that target of 79, their expected adherence should be around 92%. So if they go below that, obviously there is a warning at the bottom, reminding the patient that if there's no non-adherence, it leads to substantial worsening of disease. So there is a warning provided to make sure they hit that adherence level. So that's the suppression. We know that people living with HIV are at higher risk of certain comorbidities. So we've got embedded some risk calculators here. We've started off with the cardiovascular risk. So based on the information provided through my survey, the calculation is this particular patient has a 1.59% of a cardiovascular risk, which is categorized as moderate. And what they should be aiming for is less than 1%. And there is a health advice, 30-minute exercise per day, health diet, they should stop smoking, because this particular patient is a smoker. So again, this is something where they may want to consult further advice from their healthcare professional. Again, metabolic syndrome, diabetes, high blood pressure, and so on and so forth. Again, for people people living with HIV, again, are at higher risk. So we use the International Diabetes Foundation and the National Cholesterol Education Program approach to calculate the risk of a metabolic syndrome. Based on the information, there is no risk for this particular patient. Okay, so and there are other risk calculations in the pipeline where we're currently working on. That's the risk. There's two ways patients could have access or actually alert their clinicians. One of them is through the app directly, so where they communicate or establish connection with the healthcare professional. That's something I'm going to be demonstrating in a while. But there's also a direct alert to clinician via the app, so that a link is sent to their clinician, which they can access through a web-based portal. Let's just see how this works. They can alert their clinician either by stating their clinician's email address or phone number. Let's say this is the email address for my clinician. And I'm going to alert via my mobile. So via sending in some sort of an email to my clinician, alert successful. If you can just bear with me, it takes about 10 to 15 seconds for the email to be sent. So hopefully, just checking for email. So what will happen is an email will be sent where they can access via the dashboard. Just another few more seconds, just taking some time. I can see there's questions coming through. That's great. There's a few questions. Hopefully, we'll be able to answer all of them at the end of the demonstration. So at the end of each demonstration session, we'll go through, we'll have a Q&A session. Still waiting for the email. There we go, it's just come through now. It's alert from your patient. Here we are. So there was an email, text, and if they tap on view report, here we are. That's the alert to the clinician. So at the top, there's some patient information. I'm just going to scroll down slowly. Some information about their HIV medication, non-HIV medications, and so on. Their concurrent medical condition, diabetes. So there's information about adherence here. So it's 43%, something that needs to be discussed with their clinician. Clearly, it's less than the recommended 92% adherence. You can see some sort of a longitudinal graph. So this particular patient started using the app back in July. They've completed their survey on a regular basis, sometimes weekly, sometimes monthly. And we've extracted some key outputs from the reporting section, but we're going to have a look at that in detail. You can see that it's fluctuating: night sweat, sleep disturbances. So it's all weight loss. Okay, so this particular patient on 2 occasions have responded that they're experiencing a weight loss. Their general health, you can see there's a bit of a deterioration since July. So clearly, the discussion needs to be had with their clinician. What's exactly happening? What are the causes? Their health compared to 1 year ago, similarly, since July, there's a deterioration. Okay, it was fair back in October, November, but it's very poor in December. Happiness about life, again, I think there are signs of depression here, some mental health issues probably, and something around their laboratory lab results, viral load, CD4 count, so it's suppressed on 3 occasions. Memory loss, again, difficulty planning, and difficulty paying attention. So these are some of the outputs that we've extracted from the report, but the detail is in the devil. So we'll have a look at the reporting section. So I'm going to come out of this, go back to my app. So we've covered alert to clinician. Health and well-being, the latest survey results. So based on the latest submissions, in this case, it's suppressed. So they have a greater or equal to 400 cells per milliliter. That's the CD4 count. But in terms of quality of life and happiness and mental health, they seem to be quite poor. Something that needs to be looked at very urgently. The health and well-being. Just like a medication reminder, there's the appointment reminders where within 24 hours prior to the appointment, there'll be a notification sent through the app. There's also, users wake up for a daily motivational quote, 9 a.m. every morning. It kind of, offers the inspiration that's most needed, for the day. Often they say it kind of powers, motivates and encourages an individual, especially when you feel unhappy or lack of motivation. In fact, this came up from our focus group meetings. We've had 2 in Nigeria and 1 in Kenya, and they gave us some very positive remarks about daily motivation quotes. And something about your information needs. So this is where we kind of collate all credible information. I think it's made up of 15 or 16 different categories of information that users have access to. This could be around latest developments in HIV, latest developments around their medication, around education, legal status, and so on and so forth. There's a huge category of information. So if they're interested in, disclosure of HIV status, if they tap into it, AIDS map, a very, very prominent, reliable source where they can read around disclosure of HIV status. So that kind of is a summary of the dashboard, but the detail is really on other sections. So let's have a look at, we'll go through reports first, and then we'll have a look at the status disclosure, how users could disclose their status, HIV status through the app, and then we're going to have a look at the connection, how users, patients can connect either with their healthcare professional or a buddy. So reports, and because this is a, where you could monitor your disease over time, you can say, look, I want to go all the way back to 6 months, so July, so 1st of July until today, so almost 6 months, and I want to have a look at my, I want to keep track of my condition. So 52 out of 120, that's the most recent, okay? However, if we go back, their adherence was, fair good during the summer, but ever since it has kind of deteriorated during the autumn, slightly improved now, okay, but it's still not where it should be. So some discussion needs to be had. However, what's causing this patient from holding back in terms of adhering their medication? Well, adhering to treatment plan due to side effects, that seems to be one of the issues. Integrating treatment into daily routine, that's another. Sticking to treatment schedule because daily routine is disrupted. So these are all the kind of issues or the causes of not being able to adhere to their medication. So there's quite a detailed section within the reporting section around adherence. Cognitive problems. Again, just like what I've demonstrated during the alert to clinician, look, you can keep track of their memory loss, their difficulty planning activities and solving problems, difficulty paying attention. So the patient isn't doing very well, okay, in this respect. They could all be related to their mental health issues that they're experiencing. They're not very happy compared to a year ago. They feel depressed and so on. Physical symptoms. There's 10 different physical symptoms that we provide here. So excessive night sweat, headaches. So this patient is experiencing some headaches, some dizziness, muscle pain, lack of appetite, nausea, vomiting, and so on. So these are quite a detailed set of reports provided here. And let's just have a look at the quality of life. So as I said earlier on, there are some issues in that respect. You can see all of them are on the negative side. Okay, so that's the reporting section. And again, similar or even more are provided when there is a connection established between a healthcare professional and a buddy. They are able to see all of this set of reports. Oops, sorry. Let's now move on to status disclosure. this is where I want to disclose my HIV status. We had a case in one of the workshops where husband and wife, they are both HIV positive, but neither of them knew their status. So it was quite interesting where he came along and said, well, he wished he had the app back then so that he could use the app to disclose his status. Okay, so he's quite fond of this feature. And let's see how it works. So let's say I'm going to be disclosing to a friend of mine, Annie Smith, and it's a friend. And I can disclose either via email or phone. So I'm going to disclose through email. So that's the email. And there's a short text here. Know why you want to tell them. What do you want from them? Anticipate their reaction. So there are some notes, important notes that they should consider. They can proceed. And before they proceed, these are the information that will be shared, just like alert to clinician that you've seen earlier on. So some of the patient information. There's a text at the bottom where it says, I want to disclose to you, Anna, that I, Dermot Donodal, have just been diagnosed with HIV, but this text can be edited. They can type in, they can change as appropriate, whatever text they want to add. That's that. And if they tap on disclose, an email is sent to Anna. Okay. And there we are. That's the email. That's the email that my friend Anna would receive. Just like alert to clinician, just tap in the view report, patient information at the top. Just going to scroll down. Something about my medication, when I've started my medication, concurrent medical conditions, and well, it indicates that I'm, suppressed. My CD4 count is where it should be. However, I'm not very happy. I've got some issues around mental health that, where he needs some support, and some high-level information extracted from the report to share with the person that I'm disclosing my status to. Okay, so that's the status disclosure part. Now I want to demonstrate how connection between your healthcare professional, between the patient and the healthcare professional can be made. If you tap on connect, now if the healthcare professional is in our database, by simply stating the country, state, city, and organization, I'll show you how it works, we'll be able to find the clinician. However, if not, the user could tap on this plus sign and they can either enter the email or phone number so that a message is sent for their healthcare professional for them to download, install the app, and make sure they create the account and provide organization information so that could come up over here. So just to give you an example, let's say I'm a patient in Mozambique and my state is Nampula province, and I'm based at this particular city, Angosh, and this is my organization. And that's my clinician. So if all I have to do is just select my clinician from the list and then connect. So if I tap on connect, it says connection unsuccessful on this occasion because I am already connected. If I wasn't connected with this, with my clinician, it would have said there'll be some sort of a message saying connection successful. Okay, but I am already connected with this clinician. So if I go back and I'm going to log out as a patient, because now I need to log back in as a clinician to show how this connection works and what the clinician sees. So if I tap on, I'm a clinician, I've created an account as using my email. Okay, here we are. So that's here's my clinician section of the app. This is where if I tap on my patients, I will see a list of all of my patients, whether if you have 10, 100, 1,000, you can always, there's no limit in that sense. You can search by name, surname, or you could invite a patient yourself or patients. You can invite as many patients as you like, as you need. And if I can show this connection request over here, you'll see all those connection requests that was made by my patients. Earlier on, this is the patient information. I was Erdal demonstrating as a patient. So here, the clinician could either add the patient to the list or reject. Okay, so there is that option. And once a patient is added, this one over, this is what they'll see. This is the main dashboard. So at the top, it shows all the alerts, crucial information. We know that this patient has depression. There are some suicidal tendencies, and their adherence is below 50. Something needs to be done about it. Okay, so these are the alerts for clinician, and all their appointments and medications are all provided here. Okay, they can monitor this patient over time. So I'm just going to go back 6 months, almost 6 months. Okay, just like what you've seen in the report section for the patient, exactly the same is provided here. Earlier on, I've demonstrated, for the adherence, the clinician will be able to see all of this here as well. Okay, and in addition to what you've seen in the patient report section, there's the depression and patient satisfaction over here. So earlier on, we know that this particular patient is feeling depressed. They've lost loss of interest in life, suicidal tendencies, but there's also some patient satisfaction, whether if they're satisfied with regimen. Well, they're not. Okay, and this is quite obvious from some of the causes listed in the adherence section. They are satisfied with the clinician, very good, but not satisfied with the HIV system. So again, something for the HIV care system that needs to consider, okay, in terms of what exactly is happening in terms of the quality of service provided. So that's the patient and the depression side, patient satisfaction and depression, and something about their treatment preferences, emotional quality of life. Again, because we've just seen it, some of the responses around their mental health, flexibility in dosage, treatment combination of max 3 tablets per day. That this came up in the adherence section. They're not very happy with the number of tablets they're taking per day. This could be the reason why they're not adhering, and so on. So it just provides some information about their treatment preferences. So this is the clinician side, where just showcasing how the connection is established, and where they share their data reports for discussion of therapy. Now, what you see here is exactly the same as the buddy connection, how a patient connects with a friend, a family member, and so on. They see exactly the same information here, so that they're able to keep track of this particular patient's treatment over time. I think that kind of summarizes or completes the demonstration for the app, but we've got plenty more to demonstrate. This is just the beginning. What I want to do now is really to go through some of the questions that was asked earlier on. There's plenty of questions, okay, and I think we want to spend some time on this. Shall we start with the first question, Shola? We're going to work on this together, okay?
Yeah, sure.
Have you tested the app with adolescents, and what has been the feedback?
I think we've done testing, not just only in adolescents, but also in other age groups, and the feedback has been excellent. Even some of the features that we didn't pay too much attention to, like the daily motivational quotes. People love that, to wake up in the morning to something motivating. There was a particular patient who didn't have a good phone and decided to sacrifice other needs to be able to buy that phone so that she could enjoy the use of the app, because she understands the impact of the app will have in her daily management of the disease, especially from the fact that she knows that this app is going to save her cost of going to the hospital every time she needs to talk to a doctor or to pick up her pills, or so she decided to spend money to buy a basic Android phone to be able to use the app. So it's been very well. It's a very good experience that we've had in all the interaction we've had with people.
Thank you, Shola, for that. We've got a question by Shima Tariq. Thank you for this. How was this app developed? How were patients and clinicians involved? Self-collected. Let's ask these. Well, there's quite a bit of a question, so let's answer these questions one by one. Shola, how was this app developed? Let's start with that. Were patients and clinicians involved?
Yes, definitely. And if you listen to my presentation, there was a needs assessment in the whereby we established the need for a digital innovation, in HIV. And during that assessment, we established the different stakeholders and their different needs. And after that, we put a scientific advisory group together, including patients, clinicians, service managers, and they contributed to the development of the app.
Thank you for that, Shola. There's a comment around self-collected data impacts both patients in terms of potentially generating anxiety and clinicians, cognitive burden in already pressured jobs. Is there something you want to add for that?
I'm not sure I totally understand the question, but patients, our experience shows that patients are happy to actually use the app and supply the necessary information, especially when they realize the positive impact this is going to have on them and on their daily life as people living with HIV. So I don't see anybody. In fact, it relieves clinicians the burden actually, of having to bring patients in all the time, before they can do their job.
I think the next question is very much related.
Looks like Mosle wants to say something about that.
Sure. Mosle, is there anything you want to add here?
Actually, I just wanted to add that as a young clinician, first of all, I want to say it's very difficult being a professional nurse, especially in South Africa. There's just too much paperwork. Like, if things can be as paperless as this, you can imagine how much I can optimize the time that I want to look into other aspects of my patient. Instead of having to write down the date, writing down everything, filling in the CD4 count. If things were to get as paperless as this, I'd give a better service. I'd see even more than 30 patients a day. So I don't think this is going to actually create more pressure on our demanding jobs as clinicians. But I think it's just going to make our jobs so much easier, because remember, with ARVs, it's not just patients on treatment. It's if they are breastfeeding or not, if they are in a discordant couple relationship or not. There's so many aspects around HIV that they involve everything else around the health illness continuum, that if you talk COVID, HIV patients still get COVID. You're talking diabetes, you still find patients with diabetes and on HIV treatment, on cholesterol treatment, on blood pressure treatment, there's so many things. Like, there's people on chronic psychiatric treatment, and you need to, with an HIV patient, you need to deal with the patient with everything else that they come with. It's not just about the HIV. So I'll be able to give more time to other tasks as a clinician than so much paperwork. I mean, if things were to be this paperless, as in like tomorrow, I'd be early for work.
Thank you for that.
Yeah.
Thank you, Marcela. I mean, it shows how the technology could be used as how it could complement the current practice in terms of saving time. I think with Shima, your question, about data security kind of fits in with your previous comment about, having anxieties completing data. The next question, Shola, is how secure are these data? Who owns the data? Where are they stored? So there's questions around data security and data policy here.
Yeah, thank you very much for that question. We are a UK company, and we know that the UK takes that really rigorously. So, and the beauty of our products is that these are things that are built from first principle. Apart from the hosting, we host the data. We host the data on AWS. And on top of the Amazon Web Services, we have our own in-house built encryption technology. And the ownership is actually the patient. The patient owns the app. If they uninstall their app today, they take all their data with them. So it's the patient who owns the data, and we have a privacy policy. We have a data processing policy on our website that actually goes into the details of this. And we've also run our system through the DTAC and the DSP toolkit, and we are doing fine in terms of data security. So there's no third party things that is communicating with our product. So the chance of a hack is really limited. It's almost negligible.
Thank you for that, Shola. The next question, again, time and time again, we hear from our NHS colleagues. How do patients know to trust this app? Often they will only trust apps that are partnered with trusted HIV organizations or the NHS.
Yes, we are always willing to partner with the NHS or any organization. And that's why at the beginning, when we actually started, the first thing we did was to set up an advisory group, like I mentioned, which are mainly clinicians, mainly clinicians, service managers, and patients. And we've got contact within NHS clinicians and that we are working with. So in terms of rollout, we know that things that come through clinicians to patients are easily adopted, and that's where we're looking for partnership. We're working with already working with some trust within the NHS, but we know that this is the way to be able to reach patients, and we're open to partnerships to be able to do that. And apart from clinicians, because we're looking more on this side of the globe, in Africa, where the burden of disease is mostly felt, people are dying for technology that can help get patients on treatment and care for them throughout the care continuum. We're also seeking partnership with donor organizations and local hospitals also. So we're looking for we're opening talks with different people. We will be meeting with the Nigerian Agency for Control of AIDS soon. We've met with some organization in the Congo. We've met with an organization, RMD, in Rwanda. So we're talking to the right people that will make this the access to this digital solution to be possible where they are needed.
Just to add to that, Shima, we know the anxiety is particularly felt by our NHS colleagues. The other option that we have, because the technology is developed in first principle, we are able to store the data within NHS systems, okay, rather than our own AWS, okay, so that the data is yours and it stays with you, okay, and not with Bohemian Smart Detect. That's number one. Number two, we're also able to, I know our color scheme is blue and pink, but obviously the NHS is light blue. So we're able to kind of adjust the logos and the looks of the app so that, again, it fits, for instance, I don't know, Royal Free Hospital, for instance, or Mortimer Market, some of these well-known NHS trusts providing HIV services. Okay, so I'm not sure whether if we managed to answer all the questions, but we're happy to kind of spend more time later on that. Okay,
exactly.
we have a lot to cover. We have a lot to cover. There's more questions. I do want to go through these questions actually. How is difficulty in paying attention measured? Is it self-reported by the patient or assessed through the app?
Yes, this is self-reported for now, and I can understand where you are going to in terms of the objectivity of that kind of measure. However, we are also planning to put in some kind of brain teaser, like a game, to be able to measure that kind of objectively. So this is something we have in plan. And mind you, like Erin said, this app can be adapted to any patient population. So this is an app whereby if we get to a service that wants to deploy this, if we're working with a clinician that wants to deploy this with their patient, we will tailor it, customize it to that patient population. We've had we've had meeting with people who actually prefer a different patient-reported outcome. Other people want the Edinburgh scale. So all this we can do this rather seamlessly. So it's not a problem at all. We know that one size does not fit all, and we've built that into this app. It's very flexible, very adaptable, and we can easily scale it up.
And the next one is, I think Marlon is just one step ahead like us. I love it. It says such neurological issues are difficult for patients to be self-aware. That's correct, but could be objectively assessed through an inbuilt memory game within the app, for example. Shola, you want to say something about the game here?
Yeah. I mean, I touched up on it actually. I totally agree that measuring those kind of things using instruments, patient-reported outcome might be not too objective. And even we're working on the game. We want to gamify the app, and even with games, it's pseudo objective. It's difficult to to see how that works out in terms of objectivity. But yes, we are looking into the gamification.
Thank you for that. And a final question by Marlon: is there verification done before people self-register as clinicians via the app to guard against imposters or unlicensed practitioners?
Yes, so the good thing is that because the connection to the patient or to the clinician is initiated by the patient. So you know certain information about your clinician, and you can ask them to download the app, or you can request to be connected. So, but then when it comes to rolling this out on a service level, we can pre-enroll clinicians, and then we can pre-enroll your patient population onto the app, so that there won't be any any issue with wrong patients connecting to the wrong clinician, and vice versa. So that's definitely possible. Yeah.
Thank you. I'm very conscious about time because we have a lot to cover, a lot more to cover and demonstrate, but there's a few more questions. I think you shouldn't take long. Have we answered these? Does the patient interface incorporate African languages?
Yeah, like I said, the customization will be done to your patient population. If they don't speak English, if they speak some other languages, we can easily, get the app translated. That's why I said this is built from first principle. We can do whatever we like with the technology. We are not using any third-party software in the development, so we can do anything with it. And we've had this interaction with guys from Congo, and they want the app translated into French. So it's really something we can easily accommodate.
Thank you. Something shouldn't take long, Shola. Are the med interactions updated with new medications being available every year?
Actually, we try to update quarterly, and in fact, in due course, it's going to be almost all the time. We want to automate it such that, we pull the data, very regularly.
And Marlon just asked another question around how much data in megabytes will a patient need per month on average for them to use the app?
To be honest, we've not actually measured how much data they will need, but note that not all the features need data. Most of the features don't need, most of the ones they use day to day, like medication reminder, appointment reminder, daily motivational quotes, all these don't really need data. You start to need data when you are communicating with, for instance, drug-drug interaction. And the reason why you would need data is because we don't want to build an app that regular phones will not be able to install. If it's too huge, because we could put all those data local, but it's going to be too huge for mobile phones. However, most of the services, most of the daily need can be, can be used without mobile. Without data. And also what we want to do in the future, which we're already working on, is that even if you submit your survey, offline, when you have data, it seamlessly, updates the, update. So that's something that we're working on.
Thank you, Shola. I think we need to get cracking, move on with our next part of the demonstration. We've only completed the first part, but there's more. If we go back to the presentation by Shola, he mentioned we're bringing all stakeholders into, in terms of, supporting the fight against HIV/AIDS. I think these are the key information here. The app is an important part of our innovation, but that on its own will not be sufficient, okay, to cater the needs of all stakeholders. This is a whole ecosystem that we've taken on board. As I said, supporting the needs of all HIV practitioners. So here's a web-based platform, the way how it communicates with the app. It also interacts your electronic medical record system. It feeds data from EMR and so on. So what I want to do is I want to spend about half an hour or so, 25 minutes to about 30 minutes demonstrating this, and then we'll continue with the Q&As. The questions were absolutely fantastic. Please continue asking questions, okay, so that we can spend some time at the end answering those questions. What I want to do is I want to start with the SmartHIV clinician. Again, based on the needs assessment, we've had many clinicians who said that they would like to have a system in place where it provides the best possible treatment outcomes, with all disease-related complexities for their patients in terms of ARV recommendations. So here, what we have is, for every patient consulting a clinician, the clinician will be able to tailor the treatment needs of that patient. So here's an example. Let's assume we've got a new patient coming in who's an adult, a male, non-white, and a naive patient. So very diagnosed and they're HIV positive very, very recently. And if they're TX experience, obviously this expands. We could tailor the treatment here according to patient's needs. So they may have any mutations, for instance. They might need a treatment strategy switch where they're switching their ARV and so on. But I want to keep it simple, naive. Let's assume that this patient is on, just like the medication section that I presented, they have a type 2 diabetes, and I'm going to select anti-diabetics. So we're going to select the medication the patient is on. And they're also on some sort of illicit drugs. So let's say we're going to select cannabis from the list. Okay. If I scroll down, and now I need to select their medication. So, and the patient is on metformin for their type 2 diabetes, and they're on cannabis. They're using this particular drug. And let's see what we have. Okay, so what we have is, let me just very briefly just talk through how this works. All the clinical trials that's been conducted since 2015, okay, within the HIV arena. We've managed to compile all of the data within our database. So there's this huge number of data that we collect in terms of suppression, but fairly detailed because it kind of dives into patient characteristics, their age group, their gender, for instance, their race, and so on. So based on this, the set of 4 characteristics, it says an adult, male, non-white, naive, and they're on metformin and cannabis. It says these are the 5 recommended ARTs. And by the way, I might want to make it very clear. The outputs are compared against major guidelines. So that includes WHO guidelines, CDC guidelines, and BIVA, UK. And these are the results, the outputs generated by SmartHIV Clinician. There is an agreement, quite a high level of agreement between what the clinician outputs, the outputs generated by clinician, and those guidelines. So I thought I should make this very clear. So it provides the expected overall suppression for each of those recommended ARTs, the expected suppression over time, week 24, week 48, 96, and so on, for each of those ARTs, the expected chance of drug-related adverse reactions. So this involves serious adverse events and very milder forms of adverse reactions. That's why the percentages are relatively high. And the expected patient adherence for each of those ARTs, clearly shows that there's very, very similar in terms of the expected patient adherence. So there is some sort of a mechanism that could support clinicians. Obviously, by no means it could never replace clinicians here. And there's also some drug interactions that I've presented during the app. We have very similar outputs here as well. So not just for one medication, but all those top five ARTs as recommended by clinician. Clearly, all of these, apart from EVG, TDF, and FTC, they're very highly likely they interact with metformin. And again, apart from DTG plus 3TC and this one over here, there's a likely chance of interaction with cannabis and the ARVs. So it's a mechanism or a tool, it's a clinical decision-making tool to support clinicians here. And just like drug interactions, serious adverse events are provided. So if I can scroll down, and here we have the average chance of serious adverse events for each of those recommended ARTs. You can see about 13% chance over here on those patients on this particular ART versus 2.95% this one over here. So that's just some sort of a quick demonstration of SmartHIV Clinician. Any questions, please make sure you type it into the chat box. So that's the clinician side. I want to move on to manager. I think this one takes slightly longer to demonstrate. So we've done we've kind of demonstrated how the app and how it could potentially empower patients. The SmartHIV Clinician here supporting clinicians in terms of ART selection, particularly around comorbidity management, which is all in the pipeline. And now we want to be able to support managers, public health programs, policymakers at local, regional, and national level. So SmartHIV Manager is developed for that purpose, which is a web-based interactive planning platform for the management of HIV services. And the way how it works is it mimics your HIV service, running from Monday to Friday, 8 a.m. to 6 p.m. Everything that happens within your service, it captures all of that detail within a virtual environment. And so it captures that individual movements. You can see patients moving around, okay? Individual movements of patients from initial diagnosis to monitoring, including ART treatment, and all the resources consumed by patients as doctors, nurses, counseling sessions, diagnostics. It includes information around suppression, the failure rates, non-adherence, adherence, discontinuation, death. All of this is captured. So I always use this analogy. If every detail is captured to a certain degree within a virtual environment, you can potentially test the impact of any decision scenarios, comparing your current practice against an intervention. So the intervention could be anything as, for instance, what if we intensify our prevention program, increased use of PEP within our service or locality? What impact does that have over the next 1 year, 3 years, 5 years, 10 years? And one could come up with many scenarios to test. And so as a demonstration, what I'm going to do is demonstrate the case study we've done with City of Kigali. So what we did was the national strategic planning, as part of national strategic planning within City of Kigali, the objective was to reduce the current prevalence rate within City of Kigali of 6.3% to the national rate of 3%. And so they've got they've come up with a plan, quite a comprehensive plan in terms of the solutions that could be used to reduce this prevalence. And one of them was the prevention program. However, the report has nothing around the impact of intensifying their prevention program. What's the impact of those decisions? Okay, the impact that it's going to have on reduction, on costing, on resource needs, and so on. So here's a very quick. So the manager could be used for any HIV service around the world. So you just select your country here, Rwanda, and what it does is it updates all the input parameters that is unique for that country. Obviously, there is a difference between HIV services in Rwanda compared to Sierra Leone, compared to UK or USA. And what's driving those differences are those input parameters. And so by simply selecting your country, you're able to populate all the input parameters. For instance, there's costing. And you're always comparing your current practice, the status quo as is, against an intervention. And the interest is not about now, it's about the future. What will happen in 12 months' time, 3 years, 5 years? And just like the costing, there's your demand. So in this particular case, we're going to be projecting over the next 5 years. In the City of Kigali, there's just over 45,000, 46,000 TX experienced patients. They have about 1,600 new cases a year. That's the annual incidence rate. And we're testing against what happens if we increase the number of people offered PEP from 1,000 per year to 6,500. That's all. That's the only scenario we're testing. You can test all sorts of combinations of scenarios here. And there's a lot more input parameters within the service section. I'm not going to go into the detail, but patient attributes, the prevention split, the PEP split, your ART classes, your treatment times, because we're capturing reality. What drives within a HIV service or a system is time. The amount of time a patient spends within diagnosis, within counselor session, when they come back from monitoring. Because, as I said, it's capturing individual patients' movement over time, over the number of years that they receive treatment. And finally, monitoring visits. In City of Kigali, you've got naive patients. They come back 8 times in a year versus TX experience twice. So we're able to kind of specify how many times a patient comes in, whether if they're pregnant, if they switch their therapy line, how often do they come back, and so on. So, and also, just a very quick, before I start running the model, there's also UNAIDS section. So, you could, for instance, test scenarios. If you're a service or a country who's at around 75, for example, and what do I need if I wanted to achieve 90-90-90 in terms of how many more additional patients do you need to diagnose each year? How many of them needs to be on ART, suppressed, and so on. So we can run a very exhaustive set of scenarios. So here's a model that I've already run. I don't want to wait for 30 seconds. Assuming you've pressed this button here, run. and it kind of simulates over the next 5-year period, and you get this very detailed set of report. So just to remind you, the only thing that we've just done over here is we've run a scenario for a city of Kigali, projecting over the next 5 years, trying to understand the impact of increasing PrEP use from 1,000 to 6,500 over the next 5 years. So there's a very high level results. 51,000 patients are expected over the next 5 years, whereas against the scenario, this would come down to about 46,000 because of the fact that the number of averted cases. You expect, just over 600,000 visits in the current practice, whereas with the scenario, it's about 850,000. The reason why it's going up because you've got more people on those at risk. They are on PrEP and PEP. But I'm not going to go into the detail. There's far too many results here. I'll definitely need at least an hour for this, but I just want to very quickly summarize the results. So your service demand over the the current 12 months. Okay, what happens? You expect around, you've got 46,650 TX experienced patients and around 1,600 naive. The vast majority of the visits are TX experience related, 87.6% versus 12.4% for naive. So there's a very high level 12-month period. But then I want to go into the detail for each year, comparing the current practice against scenario. So because I'm testing for, if you can have a look, if I carry on as it is, current practice, that's the number of cases I'll get each year. But because of the prevention, you see it's now reducing the impact of my prevention. By 2025, I'll have 147 new cases as opposed to the current of 1,500. That's the number of deaths I would expect. You can see the difference between the two scenarios for each year, current practice against scenario. My monitoring visits broken down by patient types, by age group, again, between the 2 years. And something around, comparing the medications between current practice and scenario. And here we are, human resources. I'm going to spend another 3 minutes or 4 minutes, and then that should be over because I want to spend some time on the Q&A session. Summary around human resource needs. So current practice against scenarios, doctor service hours. I need 58 doctors with the current practice, 55 if I were to go with the scenario because of the reduction in the number of new cases. What about HIV specialist nurses? Okay, counselors. This is only a snapshot of the 12 months. This is the current year. But what about the number of hours required for each of these human resources? What about the 5-year plan, comparing the current practice against the scenario? So in the year 2025, I would need 55,000 hours of doctor's time providing treatment for all those patients in the city of Kigali. Against the scenario, this has come down to about 44,000. And what about the human resource requirements, over the next 12 months? Each of these, how many of them do I need? Pharmacists, medical lab scientists. So I'm comparing what if the staff are at 100% utilization rate versus 80% utilization rate. And it kind of breaks down a 5-year plan for each staff. I'm going to go very quickly, look at these, some of the dashboards. The prevention. The results are just loading. So the current 12 months, so those at risk against the scenario, number of patients within the prevention program, comparing the two, current practice versus the scenario, risk categories, number of averted cases. Look, year in year, you can see how many you're expected to avert versus the current practice, number of visits. So that's for PEP, and exactly the same thing is provided for post-exposure PEP. And finally, budgeting.
you should mention the cost effectiveness of the prevention.
Yes.
That's actually very important.
Thank you, Shola. If I scroll all the way down, this particular intervention, is it cost effective or not? Well, according to our health economic modeling, increasing from 1,000 to 6,500 PrEP users, this scenario is cost effective, and we expect around 4,700 averted cases, which is costing us around $604, for averting each case, and there's some more detailed results. So, if it's not cost effective, it clearly states that it's not cost effective. But on this occasion, it is. Thanks for the reminder, Shola. And your budgeting needs over the next 5 years. How much do you need? And it's broken down by first line ART costs, laboratory costs, staff costs, second line costs. So it's comparing your current practice against the scenario in terms of your budgeting requirements. So this is what we mean by saying it's an interactive planning platform for the management of HIV. This could be at the, the local level, regional, national level. You can test new scenarios. I mean, we have the integrated care pathway in the UK, for instance. That's something we can incorporate over here and test all the impact of this. Nurse-led clinics, that could be incorporated. What about voluntary male circumcision as a prevention, or increase or condom use, or combination of these that could be tested? And the accuracy of the results are up to about 95%, because it's far superior than any Excel-based or mathematical models. I don't want to go into the detail of that, but that's something we can touch on later on, because of the robustness and the accuracy of the findings. You need to bear in mind, Shola mentioned during the presentation that you can link your electronic medical record system, so that all of these parameters are updated, just communicating with your data. So it just grabs all of the number of cases, broken down by patient age, gender, for instance, and so on. The number of follow-ups they have in a year. Okay, that could all be fed in the model through HIV SmartLytics. Okay, I'm not going to go into the Smart HIV try list. Maybe some other time, because I want to spend some time on the Q&A and the discussion part. Okay, that kind of completes a summary of the demo. But before we start our Q&A session, I want to have our panelists, which we've got Emmanuel and Mosale, to have, you've got about, you could have five minutes each or thereabouts, okay, to come and share your experiences, okay, in terms of, some of your past related projects that you've been working on, and hopefully how SmartHIV Solution could potentially support some of those programs. Emmanuel, do you want to step in and talk through for about 5 minutes? Would that be okay? Is Emmanuel with us? I think while we're waiting for Emmanuel, Mosale, do you want to step in?
Yes. Well, currently, I've started doing a bit of research into starting my own practice. And I've had a lot of clientele demands for people that really want a practitioner that they can relate to without queuing up and all that. And I worked around improving most of my skill. I've upgraded my HIV clinician qualification, currently busy with my neonatology and advanced midwifery. And if we've got an integrated system such as this, it's going to make it so much easier for me privately practicing, because then it means I can also buy into this and be something that I use on a private practice capacity. In most cases, most of my clients are PMTCT clients. So remember, we're working towards an HIV-free generation, and we still have integrated management of childhood illnesses to consider. There are still kids that we are initiating concentrating on ARVs, and that's not what we want. So it means we're failing somewhere. And when I see new innovations like this one, I can think of so many possible successes that I will get in terms of getting negative PCRs from newborn babies and allowing mothers to breastfeed successfully without transmitting this. Because what I've noticed is some of these mothers, they become so overwhelmed. It's the pregnancy. In South Africa, we've got a Mom Connect, but Mom Connect does not integrate the PMTCT into this woman's pregnancy journey. It just talks about gestations, what to expect, danger signs, in the form of an SMS. It's not even an application, it's just random information that is being sent out. So this also allows the client to also interact with the clinician. It gives us this relationship where we can consistently be in contact with each other so that I can ensure compliance. Now, we are getting a lot of people that are being diagnosed with HIV, a lot of people that know their HIV statuses. But we need to get more towards the goal of having 0% infections in babies born from mothers who are HIV positive. We need to get a more integrated system that allows discordant couples to have a platform where they're equally accommodated, you know, because everything revolves so much around the pregnancy and then nothing after that, and nothing for anybody that is newly diagnosed that is not even planning to have kids. I mean, we've got young professionals that are being diagnosed with HIV, and this would be so much of a convenience than them leaving work and leaving their careers or class or studies to go and actually inquire information. They can just connect on the app and talk to a clinician. I've been involved in a lot of projects with ANOVA, and ANOVA is one of our institutions that caters for same-sex relationships, and they also have their own challenges when it comes to HIV. So this is such a more broader platform for any patient that is on ARV treatment or that has been newly diagnosed to be able to get assistance. I think that this would make my life so much easier, because I deal with mother and child, and I still deal with youngsters, and I'm still your sexual and reproductive health care nurse. I must promote contraceptives. And I've noticed that sometimes teenagers rather would deal with an app than to come and talk to me. You know, some of them feel like we're the same age group, or they feel like I wouldn't relate, or some of them feel I'm too young. So on this kind of a platform, it also gives the opportunity of clients that actually are a bit shy to be able to interact and talk openly to a clinician, or interact on a buddy system anonymously. So this is going to work hand in hand with all my actually.
Thank you for sharing for that, Marcella. We had from our the workshops in Nigeria and Kenya, this issue around stigma came up quite often, because what several users during the workshop expressed is that, you know, visibility of going into a HIV clinic, even for a routine appointment, was highly stigmatizing. And what some of them said was that the app in that respect could act as an intervention to reduce stigma, simply because it kind of you know, removes the need of visiting clinics just for routine visits, you know, something simple as picking up your medication. So thank you for that, Marcella.
Yeah, there's actually a paper that was written by guys from Rwanda about newly diagnosed initiating treatment, and they feel it's highly stigmatizing to go into the clinic, you know, to be seen, because they're still looking very healthy, and being seen around HIV clinic is already very stigmatizing. And in terms of disclosure, I was responding to some comment earlier, because disclosure can also be to your clinician, can be to your family doctor, and you know, and if you disclose to your doctor with a bit of information that you submitted via the app, the person can, you know, get you help without you coming into the clinic.
Thank you for that, Shola. Marcella, can I also pick up on something actually when you mentioned how the technology could help in terms of releasing capacity, because if we're able to reduce unnecessary visits, I think the unnecessary term is used loosely here. We might need to kind of open that up in terms of what is unnecessary and what's not. But I do remember in one of the discussions you did say that you've got overcrowded clinics, and which is a big issue. And so if the app could be used for that purpose, can you elaborate on that just a bit?
Shortage of nurses as is, especially professional nurses. And I mean, we've got nurses in hospital care and in primary health care. And in primary health care, that is where the demand is for HIV clinicians. So you find that the HIV component is being dealt by one person. Now, if I've got every second person that's coming to ask me about side effects and blah, 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 and I still need to see patients, initiate patients on treatment. Remember, we take our own blood in primary health care. We don't have phlebotomists coming in. So you are multitasking somewhere in between, filling in the file, taking the blood, making sure that it gets to the lab on time, signing for everything, following up on the results, So I think if we even have this integrated electronic system whereby I don't literally need to go on the NHLS app and download every other result and it's just updated on a system, it's going to make my life so much easier. Because sometimes even if the system is down, I wish I had a similar app on my phone at least, so that I'll be able to use it, because then it means whether the system is down or not, I'm not failing on following up on a patient's result, and I know what kind of care plan I should be having for them going on forward. So it's also going to save, because remember, you can start a patient on treatment, but their adherence is very much dependent on a buddy system. So if we've got this kind of a buddy system in their app, then it's no more about me trying to create sort of like adherence sessions between me and the patient. Then this is just them being drug ready with an app, and we can just focus on the more important things that inquire clinical practice. Because on an emotional well-being, I don't think we are awarding our patients enough time to interact with us on a psychological and emotional level. And that kind of well-being is what we need for patients to become adherent. Because the discipline to actually take a pill every day for the rest of your life still requires some kind of discipline. It's the same as going to gym or sticking to a diet. You are going to have bad days, and you do need some kind of support structure. And in my country, I'm unable to give total 100% support to a patient because of the patient influx that I need to see on a daily basis. So it's honestly, it's not the unnecessary visits, but we are on a shortage for human resources and an even greater shortage for HIV clinicians, because other professional nurses are practicing clinicians, but they don't deal with HIV. So that minimizes even the number. Based on the amount of infections that we have, we've got very few clinicians that are actually dealing with HIV.
Thank you for that, Marcella. I think this issue of capacity is everywhere. It's especially nowadays.
It is terrible. The overcrowding, like really, I could do with less of it.
Yeah, I think it's all about trying to find ways of changing our mindset to have these kind of digital solutions being adopted as a means of complementing the current practices, as opposed to, I mean, obviously nobody can substitute a face-to-face visit. I mean, that could never happen, but at least the solution could work together between face-to-face visits with clinicians and as a tool on its own. Antonio, you've got your hands up. We've got a
yeah, I just wanted to follow up on a question that is in the chat. Maybe we can answer it in the live. It's about whether we have tested the app with adolescents and what has been the feedback.
Yeah, I think I must have taken that question already. Yeah, we've tested it in adolescents and even in other age groups. So, and the feedback has been awesome.
We've got two more questions here, actually. Shola, is this subscription charge dependent on individual patients, health facility, hospital, or national health system?
Actually, it could be any. It could be any of those. So currently, if a patient is downloading the app, so that will be at patient level, because they need to pay the subscription to be able to have access to the premium services. However, if a health facility thinks this is something good for their patients, and they want to enroll their patient on it, we can charge the health facility similarly to the health system. If the health system thinks they want to roll it out nationally within the health system, we can discuss what kind of customization that will be necessary, and then decide on how much that is going to cost, and we could roll it out also at the national level.
There's all sorts of kind of options here in terms of the subscription. Okay, thank you.
Absolutely.
So that question was well, thank you for that question, Clement. We've got another question by Marlon. Does the clinician interface carry telemedicine capability, diagnosis and prescribing treatment of opportunistic infections?
Yes, absolutely, because what happens is that the app communicates with the SmartHIV clinician, and through that, diagnosis, prescription of treatment, management, opportunistic infection, and other comorbidities is definitely, something that is captured in the current development. And in fact, as part of the comorbidity, even within the app, we know that in most parts of Africa, most medications can be bought off the counter. And one of the reasons why clients tend to, disrupt their medication is because they take a co-medication without knowing the impact it will have on their ART. And then when they see the side effects, they tend to drop off treatment. With the app, they can actually check if whatever co-medication they are taking off the counter will be interacting with their HIV medication. And that's part of the empowering patients to take certain decisions without having to call the doctor to say, I want to take paracetamol, should I take it or not? So at least some kind of decision at the client level. And of course, there's the possibility to connect to clinicians and talk to them when necessary.
Marlon, just to add to that, there are some additional features that's just been added. For instance, the medical laboratory results, for instance, that could be added so that you can share that with patients via the app. Okay, so that's something that could be very useful. And also pharmacy. Shola, do you want to mention something about the pharmacy that's currently in development?
Yeah, just like we always say, what we have is a solution that is highly adaptable. So depending on who needs what, we can adapt it to the service, to the patient population. We have already implemented the medical lab, whereby patients can go into a community lab, get the test done, and push the results through the app, which will be available to the clinician also, not only within the clinician dashboard of the app, but also in the SmartHIV clinician, the web-based dashboard. We also have the pharmacy that is implemented, whereby when the threshold of pill refill is met, there's an alert that goes to the patient if they want to order a refill, and if they say yes, an alert goes to the prescribing clinician, and if they say yes, they prescribe, the patient then has the opportunity to pick which nearby pharmacy they want to pick their medication from. We have so many community pharmacy nowadays, and the clinician can then prescribe and make sure that the refill is at that chosen community pharmacy. So these are all possibilities, and that's what I said in the previous session. We are a company that we identify a problem and we look for solutions. We don't just stop thinking because there's a problem. And this is the beginning. We are adding new features, we're adding new capabilities, and the sky is actually the limit of what we can achieve with this solution.
And we just need to bear in mind, we've only launched just a few months ago. However, the R&D has been going on for a couple of years, but a lot of these methods is something that myself and Shola have been working on for 15 years. So it's been many years of hard work, research that we've put just to be able to develop such an approach, because it's not an easy thing to do, to be able to develop all of these tools supporting, catering the needs of well, literally every HIV practitioner or those involved in the management of HIV, including the patients at the center. So there's a lot of hard work. It's still the beginning, and there's a lot that needs to be done from our side. Any other questions? Do we have anything? I mean, don't be shy. You could ask any question, anything that we haven't covered, anything you might want to add.
Just want to say that the recording is going to be made available, and also if you have additional questions, if you would like to have a one-to-one demonstration on the app, or if you want to further discuss it with the team, just please feel free to drop us an email. I'm going to post the details in the chat, and we are also going to follow up with an email with all this information for everyone who is interested.
Thank you, Antonio. Thank you. Well, before we close, I want to give a final word to Mosela and Shola. Okay. Mosela, do you want to say something before we move towards the closing of the session?
Just in short, I think there's a lot that can still be done with this app. It's got a lot of potential to actually take over most of dysfunctional applications, because I think we have been walking around eggshells around HIV for too long. And looking at the entire health illness continuum, I mean, it's gone on for so long, and it's a global problem. It's not even just about South Africa alone or Nigeria alone or Kenya alone. Like, it's a global problem. We've been walking around eggshells around it so much that we focus so much on the stigma than anything else that goes into it. There's so much more. I mean, we've got newly developed drugs with less side effects. I mean, we're supposed to look into what actually it can actually bring in our lives as clinicians, even for patients, even for communities at large. I mean, this is one technological solution I think is just going to take healthcare into a totally different level, whereby I think it's enough. We need to cut it down. The paper that needs to start becoming paperless now, because there's a higher demand on the not so many hands of clinicians that need to deal with HIV patients. So with a development like this one, I think we can say we're looking into first world, even in underdeveloped countries like ourselves.
Thank you for that, Mosela. Shola, do you want to add a few words?
Yeah, thank you very much. I know we can make excuses about anything, but like I always say, when there's a will, there's a way. We always say the issues around how to implement this in rural Africa. For people in rural Africa are not actually complaining because we've rolled this out in different parts of Africa, and there's no complaint. And I think it's just because we are so used to the status quo, and we are reluctant to change. And that's why the system is built in such a way that it can be integrated with the existing systems. We are not saying do away with your system. And I think if the donors, if the donor organizations, if the government, if they made the right investment, even if they have to buy simple Android phone for every of their patients and enroll them on the app, they are going to save a lot of costs. Current wastage is going to become minimal, and it's going to be cost saving at the end of the day. So we just need the courage, we need the will to be able to make a way and make sure that we bring this pandemic, the epidemic into the end. We want to end it, and we now have a digital solution that can only support us to end the epidemic, end stigma, end inequality, and end discrimination. Thank you.
Thank you for that, Shola. I totally agree. It's just a matter of, we have all of these technologies at our disposal, but it's just a matter of doing things differently. And as I said, changing the mindset of key decision makers, policymakers, is not an easy thing to do. There's always barriers towards adopting such technologies, but it's our duty to showcase how these could be used, to end, we use these buzzwords, end inequality, end stigma, end AIDS. But if you don't do things differently, I don't think it will ever come to an end. Okay, yeah. We'll just
Sorry, there's a question that just came through.
Okay.
If anybody saw it. What platforms is the program or operating system able to work on? I don't know what system this question is all about, but if it's the app is both on Android and iOS. And the other solution, the SmartHIV Solution dashboard, is web-based. So it can be any web browser, actually.
Thank you for that. Just a last minute question. Any other last minute question? Please don't be shy. Just another few more seconds. I don't mind waiting for another few more seconds before we close the session. It's almost five to hour. But I'd like to really thank all participants for at least allocating your 2-hour time for this. I think it's been very, very productive in that sense. I'd like to thank Mosala, our panelist here, you've done a great contribution. I also want to thank the African CDC Conference on Global Health Africa for allocating a 2-hour session for us, for this event. So thank you very much, everyone, for your participation.
Thank you, everyone, and please be in touch if you need us to, have a one-on-one demonstration, or you want to talk about any ways we can collaborate. Please reach out to us. Thank you very much.
Thank you very much, everyone. Have a good evening or afternoon if you're in Florida.
Thank you. Bye.
Thank you.
Thank you. Bye, everyone.
Bye. Bye. Bye.
Guys, now you don't want to go home.
No, we don't. We love everyone. We love it so much. I'm just reading some of the messages.
Yeah, there's actually some very interesting comments.
I'm going to stop the live recording now, and I'm going to close the session.